Again, thank you for having me here at OLLI. I'm enjoying doing this. When I originally proposed this, I was proposing it as a kind of a semi-book report, but making it much more relevant by applying the 10 items that are talked about in Factfulness to the coronavirus, which I sometimes refer to as COVID-19 or C19 for shorthand. This book, Factfulness, is by Hans Rosling, is quite an interesting book. Barack Obama said that it's a hopeful book about the potential for human progress when we work off facts rather than off our inherent biases. In other words, what the book is pointing out is there's 10 biases that we all have that make us look at information different than what might be the correct way to look at it. And we're going to do each of those. And Bill Gates says it's one of the most important books he's ever read, A Guide to Thinking Clearly. And in the Observer, it was named Book of the Year as a powerful antidote to persuasive pessimism and populist untruths. So what are these 10 instincts that we supposedly have that cause us to get the information that we are being given wrong? And I'm going to go through the 10, I'm just going to list the 10 instincts and kind of what they are in general. And then we're going to go back through each of them one at a time and apply them to this C19 pandemic and see how they have been misleading us in our conclusions. Now, the first one is gap, and the gap is we have a tendency to categorize people by extremes. That is, we're either rich or poor, and people are thrown into these two extremes. There's no overlapping. And this gives us a thinking of it's us versus them kind of mentality, as opposed to it's really a continuum from one, in the case of rich to poor, it's really a continuum from rich to poor. And there are people all along the continuum, and people who we might consider rich, others might consider to be poor, and so on. What the point is, you can get misled if you were thinking of a us versus them, racially, religiously, by country, any other way, where it becomes a character. The second instinct that we get in newspaper broadcasts, I think that one's fairly self-evident, and we're going to see how how C19 is affected by that. Straight line, we tend to think in straight lines, that the chart on the straight line on the chart will continue forever. Again, going back to C19, the chart showing the number of new cases and new deaths looks like a straight line and looks like it's going to go up forever. Yet straight lines rarely go on forever. A fear that it's scarier than it really is. Going to have a fair amount of talk about that on C19. We have an instinct to think things are more scary than they really are. Size. If you don't have a reference number to compare the number you're being given to, either as a percentage or as a reference of a similar situation, you have a tendency to misjudge things because you don't have that reference. For example, I think we're at 2.5 million cases worldwide of C19 right now. That's a huge number, but yet compared to the average annual flu is not a huge number. Generalization, everyone in the group is similar. I mean, this one is very common, and when we judge people from different ethnic backgrounds, different religious groups, different countries, we generalize that they're all this way, and when in fact they are not all similar. They have the same spread in them that we have in us. Destiny. We have a tendency to think of a group or people in that group that they aren't going to change, that they'll never change. Yet you look at, for example, young people. Young people have a tendency to be a liberal, not to be very careful with money and so on and so forth. Yet we know that those people, that group, will change as they get older. And that's just one example of many that that groups and people change. Single is a problem has a single cause and a single solution. Like with C19, it's much more complicated than a single cause and a single solution. Blame. Scapegoating, C19, blaming China, blaming Trump, blaming the Washington, blaming Tallahassee, blaming, just finding some scapegoat and to blame is not overly productive. It's more getting to what is the true cause and working with that. But we all have that tendency. We all have a tendency to find a scapegoat and blame them for the problem. Urgency. This is an urgency to jump to action without knowing the facts. And this has happened over and over again in C19. I mean, I could just think of so many. The first thing was thinking it was not going to be particularly serious and life would go on. This was back in February. Then there was a jumping to the fact that it was only going to be a China situation. Then there was the belief that there may be an existing drug that could treat this successfully, maybe even prevent it. And this is jumping to action without knowing all the facts. And again, a common mistake we all make. And the only point of this book is to help us learn to be more nuanced in our approach towards news, to recognize that we have these built-in instincts that can cause us to misjudge a situation, come up with the wrong problem, the wrong solution, so on. The first one I'm going to do, and that is gap instinct, that we have a tendency to divide things into two distinct groups and imagine a gap between them. Again, going back to C19, maybe it was initially we thought it was China versus the world, and that the problem was a Chinese problem and not a world problem, by imagining this big gap between us. And to control that instinct, what you need to do is look at the spread. And if you see the spread, rich, poor, Chinese, the rest of the world, and on C19, if you look at the spread, the gap disappears, and you can now see it much more clearly. You aren't as misled by thinking that it really is two distinct groups. Now, the media loves to compare extremes because that's a clever way of developing a story. A story will start with an example of an extreme, and then we'll generalize from that extreme. And you're reading it, and there's no question that the media is correctly reporting what happened to that one person or that one group, and that it looks bad. and then there'll be an implied, well, this is the normal, this is, rather than this is one of the, then this is an extreme. So, you know, just as you're reading a story, recognize, ask yourself, is this person or group an extreme group, or is it a average group? And are we putting people into two distinct groups, or is it a continuum? And these people represent some edge of the continuum. And as I said, in coronavirus early on, it was China versus the world. And it turned out that this was thinking of C-19 in those terms was an easy gap, but unfortunately not a correct gap, because now it's the world. Because then it spreads to the other countries, and we should have used that time to better prepare in retrospect. This is a graph that I've thrown up here to show you how C-19 has shifted from being an Asia, them versus us, to a North American problem in just 30 days. So you see back there in March 1st, it was primarily an Asian problem with 70% of the new cases or new deaths occurring in Asia. And now it's a month and a half later, it's shifted. So it's heavily a North American problem, with the US leading the world in new deaths per day. And the point is, in this period when we thought it was an Asian problem, kind of an us versus them problem, if we had only recognized that it could well become us, and we had used these days in here to better prepare, make more tests, get the hospitals better set up, start the quarantine a little bit earlier, we might have not shifted this so much over to the US. Number two is the negativity instinct. And this is, we tend to instinctively notice the bad more than the good. And when in fact, things can be both bad and good at the same time. And the example that the book gives is educational levels. Worldwide, the educational levels have improved over time, which is good. They've improved massively, actually. But there's still 10% of the children in the world don't get any education, and that is clearly bad. So it can be good and bad at the same time. And I think if you were someone who is deeply concerned about the 10% of the world's children who don't get any education, and you want to help solve that problem, probably that problem, because it's a negative problem, will speak to many people. But it may be better to say it, that to acknowledge when you're saying that 10% aren't being educated at all, that the other 90% actually are getting a better education today than they were 25 or 50 years ago. And that a number of people have moved from the non-educated to at least partially educated. But the good news is never reported. The percentage of kids that are moved from not receiving any education to receiving some education, or moving from some education to a adequate education, is good news that doesn't get reported. It's a gradual improvement that just isn't reported. And then you have the countries and the government and the media always trying to glorify the past. So we got to be aware of these rosy pasts, that back when it was much better. Things are going downhill. So this is on C-19. This is applying this principle to C-19. What you get is you get the daily new cases and new deaths are reported. Yet here, these are in the United States, it's a graph of the new cases in the United States and a graph of the new deaths in the United States on a daily basis. And I drew a kind of a red line on both of those, red dashed line on both of those, showing that it sort of has peaked out since the end of March. It's not still climbing that incredible vertical, that sloped line that you see from March 15th up to April 1st. You see a very rapid increase in the number of new cases that looks like it's going to go on forever. And considering that it's only hitting small portions of the United States yet, you'd say, oh, this is going to be awful. But yet, for reasons that aren't terribly clear, but reasons I'm going to go into later in this talk, it seems to, in the last 15 days, sort of leveled out at around 30,000 new cases per day. And then the same thing happens over there when you look at the new deaths. They skyrocketed from March 20th to April 6th. And then they sort of peak out. And of course, they're going to peak out a week after the new cases, because deaths normally occur about a week after someone has a case so serious that it becomes a confirmed case. But yet, you look at that and it looks like maybe we're getting that under control also. Maybe, let's hope. But the point back here is the negativity instinct. What sells newspapers and keeps us watching the news is the negative consequences. And I don't mean that the news people are bad or doing anything wrong with that. It's just the way it always has been and the way it still is. The straight line instinct. You see the line going up and you assume that line's going to go up continuously forever. And let's go back to this graph. See this? See on April 1st right here, you're right here. And this line's been going up like this. Naturally, you're going to project it to go up like this. There's going to be an increasing number of new cases every day. And yet, turn and flatten, I guess, primarily because we all went into semi-voluntary quarantine around April 1st. But it's an example of a straight line instinct where you think the straight line is going to go up forever, or at least for the foreseeable future. And it turned out that trees don't grow to the sky, and it turned out that somehow we got this C-19 under some control. Just because it looks like up until April 1st, it looked like it was a straight line. Yeah, it would have been reasonable to project that straight line to go forever. Just recognize that trees don't grow to the sky and that most lines don't go forever. Now this is a different, the graph that I showed you before was the number of new cases each day. This is the total number of cases. And this, when plotted on a linear scale is when there's the same distance between each of these. So 200,000, 400,000, 600,000, 800,000 cases. And the time here is 1 day per dot. So what you see is this line is just going up. It looks like it's a straight line, looks like it's going to go on forever. Yet it's unlikely to go on forever. Here is the Chinese data. You see from China, they started out on this very rapidly rising lines, and where it was doubling more rapidly than once every day, once every 2 days. I mean, I'm not sure how fast it was going up. Probably wasn't going up doubling every day, but it was going up very fast. And you see the little numbers on here. These are the days, day 10, day 11. Well, around day 11, day 12, it starts to tail off and comes over. And then they had a miscount. They recounted, so then it jumps up here and then it kind of flattens out. The point being that, again, that these straight lines don't last forever. The fourth instinct we have to be aware of And I think that's all it is just being aware of it more than getting us into trouble. Just be aware that we have a built-in fear instinct, and we tend to perceive the world as scarier than it really is. And we tend to overestimate the associated risks with violence, captivity, contamination, etc., plane crashes. And contamination, in this case, we're referring to the contamination from C-19. It is scary. There's no question it is scary. But we tend to perceive the world as scarier than it really is. It may not be as bad as we're making it out to be. And we have to halt. When we read the latest headline, we have to stop for a second and say, gee, that is really scary. But we have a built-in tendency to think things are scarier than they really are. And a part of it is that part of the reason the world seems scarier is that, of course, we hear and are fed information that makes it a scarier place. Again, what sells news is what bleeds leads. The news, if anything, is feeding us with a little more scare than maybe it should be. The real risk is the danger times the exposure, and you got to act accordingly. In an airplane crash, you know, what is the real risk that you're going to be killed in an airplane crash? Well, the engines fall off the plane or whatever happens to the plane and it starts a dive, the danger is pretty high. But how often is anybody exposed to that? I guess we can look in the recent past and look at some of those Boeing, I think they were 737 Maxes, where due to a software error, the pilots lost control of the plane, and the plane started doing a roller coaster, winding up into crashing. But that's pretty low, pretty low risk. On the other hand, if you're on the Princess Sapphire cruise, the danger and the exposure are pretty high, and a lot of people came down with the virus. And one way to fight this is try to make the decisions only when you're calm, not when you're afraid. Is to say to yourself, this really scares me. I need to calm down, maybe talk to someone, get myself in a calm mind, and then re-examine what I'm afraid of and why I'm afraid of it. It's not that it isn't real, it's that I may be over-exaggerating how real it is or how dangerous it is because of this built-in fear instinct.
Real quick, one says the C-19 good news is the recoveries, but it is very hard to find that on any C-19 state site, easy to find deaths.
Yes. One of the reasons I was a bit late joining you guys this morning is that I have, from 7 o'clock this morning, been going into a new study out that re-examines that whole question of how many people have been infected with C-19, how many of them know they were infected, that is, they have symptoms as opposed to no symptoms, how many of those have wound up in the hospital, and how many of those have died. And there's new data out this morning that I was debating furiously back and forth with my colleagues as to what it means. So you are right that we just do not know, and as I wound up saying in my last email out, we just don't know whether this data was, you know, the reviewers of this data are both positive and negative towards the study. Good and valid reasons to be on both sides. We'll get into that. That will be slide number 24. And I suspect that will generate a lot of conversation. But but you're right. C19, we really don't know what our danger is, what our risk is, because we really don't know yet what the danger is and what the exposure rate is. And that's what this new study that I'm going to get into later deals with. And it may change, you possibly may leave this morning's talk with a different impression of what your risk is. And it's possible that you may not. You know, as I keep saying, I'm not a medical doctor. I'm an engineer, and I look at all problems from an engineering standpoint rather than from a medical standpoint. Not that there isn't some validity to that in this C19 issue. Different people come up with different conclusions, different evaluations of the risks.
So another question is, do you have any thoughts about the news stories that recovery from C19 does not guarantee immunity? In other words, one can catch C19 for a second time, or is this an example of negativity?
Great. Both of those are great questions. This is a great question also. And, you'd be a lot better off if I were a medical doctor. It's true that I have read, I don't know, countless articles, because for some reason I got interested in this, and I've read countless articles and studies and tried to figure this out. A medical doctor might see implications into it more valid than I do. I don't know how valid all the studies are. I don't know. As of this morning, I'm thinking that we have a less severe crisis than we had before. Not that the newspapers and the television and the politicians have hyped it. It's just they don't know either. New data that's coming out this morning seems to me to indicate that it's not as bad. Now, as far as your exact question, if you did not develop, if your immune system in your body, as I understand it, if your immune system in your body did not fight off C19, did not develop an antibody system and successfully fight off C19, you would get progressively more sick. So anyone who has recovered has an immune system which has successfully fought off C19. That could be with or without supplemental pharmaceutical drugs or therapy treatments. If you have recovered, you have some level of immunity. You have some level of antibodies, which gives you some level of immunity. Otherwise, you would never recover. Now, the valid question is, okay, how good is that immunity? How long is that immunity going to last? The standard flu vaccine gives you an immunity for about a year, and then it wears off. And that vaccine is generally given against last year's flu. And if they are kind of guessing how the flu might mutate, it might be against some mutated version of last year's flu, or it might be against a new flu that they picked up somewhere that they were able to get a vaccine for, and then they combine it all in one shot. So that gives you reasonable immunity. Maybe who knows? Let's call it 80%. I think I've seen that number before. And if you come down with the flu after having gotten the vaccine, you'll get it less severely than if you had not had the vaccine. And for many people, it gives their immunity system enough of a boost and enough of a head start, so they're able to fight off this year's flu without becoming very sick. In fact, perhaps without even noticing it. And then in the process of their bodies fighting it off, even if they have not noticed any symptoms, their body has made antibodies and so it is now immune against this year's virus. So I think that's kind of how the whole thing plays out. I see a hand up from Michael Kahn.
Yes.
Well, the first thing I wanted to do was alert everybody to a chat HTML address, a URL that addresses some of the previous chat comments, and that is that site, epidemic-stats.com slash, is a great everyday update where you can do ascending and then descending ranks of all the countries involved, all the reported cases confirmed, all the deaths, all the recoveries, the mortality factor rate, the comparison per million of each country, the number of cases per million, where even though the data on the input is still pretty flawed compared to what it should be, at least relatively, you can see where the United States falls with every other country in the world and get some feel for those countries that are more getting better control of it versus others. I know it's kind of a side piece of information from what we're exactly talking about, but I wanted to alert everybody that I really think that's a good site.
Thank you, Michael. That is, and there are a number of them I've been using. One is from Johns Hopkins, and there's a number. I assume they're all pretty much the same data, and you are right. They really do give you a different opinion. I'm going to show later. I'm going to show a couple graphs that show the number of cases per million in the United States versus all the other major countries, and the number of deaths per million in the United States versus all the other countries, and both of those numbers versus the standard annual flu hospitalizations and deaths.
Yeah.
So I like where you're going with that. And I think it was highly relevant, and I've included it in
One more from Rita, kind of maybe on the lines of what you're about to tell us, is have you come across any information comparing the mortality rate for C19 as compared with the Spanish flu of 1918, 1919?
Yes, I don't have that graph, but I did another talk on it recently, and the Spanish flu's death rate per million was about 50 times the death rate per million of the average current, the past 7 years U.S. flu rate. The present flu rate in the United States, the average over the prior 7 seasons has been 106 deaths per million. The Spanish flu rate was about 5,300 per million. But the proviso that I throw in there is back then we didn't have the healthcare system we have today. And the prior years, in the 1918 flu was this 5,300 per million rate. The 1917 flu rate was about a quarter of that. So the normal flu deaths back in 100 years ago, deaths from flu was running, at least in 1917 versus 1918, was running 12 times what we have under a normal situation, and 48 times or 50 times under the 2018. So 2018 was 4 times worse than 2017's flu, which was 12 times worse than our average flu today as measured by deaths per million. So I wanted to spend a little more time with this risk versus danger. Here are the death rates by age. So what we're seeing is that in 10 to 39-year-olds, there's about 0.2% death rate. And the death rate is, we know when a person died, and some but not all of these deaths have been validated by having taken a test. They would be called confirmed deaths versus suspected deaths. And I suspect this is suspected deaths rates in here. And then that is compared to known cases. And since we don't have the test kits, we don't know how many cases are really out there. We don't know if the known cases are the ones that people show up at the hospital with symptoms that are pretty clearly C19, and hopefully they got a test to confirm that they have C19, and then that number is compared, the number who die are compared to the number who show up. But how about all those people who come down with C19 and either don't get any symptoms at all or treated at home and are not included in any data? And so these numbers could be very high because we don't know. They're 0.2% of reported cases, and we don't know what percent of actual cases are reported cases. It might only be 10% of the actual cases become reported, or maybe even 1% of the actual cases become reported, depending upon what we're going to find out over the next year. But then as you go up this list, you do see that over 80-year-olds, that 15% of them that become known cases wind up dying, at least on this earlier data. And one would, so as you get older, your immune system isn't as good, but so often you have a comorbidity, one of these other conditions that are on this other chart, that greatly increase your risk of illness and dying. And it could be that a healthy 80-year-old gets through this not as well as a healthy 20-year-old, but not a 15% death rate situation. On the other hand, if you take an unhealthy 80-year-old that has one of these conditions over here, it could explain why this number is so high and that most 20 and 30-year-olds don't have one of these comorbidity conditions, pre-existing conditions. So the risk is, what I take out of this chart, what my takeaway from this chart is, if you're over 60, if you're over 50, consider quarantine. If you're over 60, definitely be in quarantine. And if you're over 70 and 80, be in deep quarantine, and bomb shelter quarantine is what I'm saying. And if you have one of these pre-existing conditions, even if you're below 50 years old, if you have one of these pre-existing conditions, play your quarantine very seriously, because that's what I see as the risk, the true risk, the exposure versus the danger, where these charts show you the danger and the exposure is yet to be determined. So the current danger in the US is, as of last night, we had 750,000 cases and 330 million people, or about 0.25% of the nation had been labeled as having come down with C19, had been identified, or about 4 per thousand. The question that is very, very big today is what number of people actually have come down with it but have not presented symptoms and therefore are not included in this 750,000 count? And is that number 10 times or 100 times this? And I think that's a very interesting question.
On slide 13, are there any stats which combine both charts? For example, stats broken down, people with no pre-existing conditions split out by age.
Surprisingly, I could not find up. I did find one. Yes, there is one that I can recall from memory. One was that people with pre-existing conditions have 5 times the death rate of people without pre-existing conditions. And I'm not sure that's universally across the age bracket, but if you say that, look at this 80-year-olds, that's 15%. So trying to apply that to there, if you come down with an identified case, which means that you've gone to the hospital and you're 80 years old and you don't have any pre-existing conditions, you might have around a 3% risk of death. If you're an 80-year-old and you go to the hospital and you become identified as a known case and you have one of these pre-existing conditions, you got a 15% chance. I'm just trying to do this in my head, but try to give you a feel for how I would read that data. No, I do not. I've not seen, I would love to see the chart that you're talking about. I'm sure somebody's working on it. I have not yet run across it. The size instinct. We tend to overestimate the importance of a single event or a single person or a standalone number unless we have a comparison. And the lonely number may seem impressive in isolation, but can seem trivial when in proportion to something else. So when we compare countries or whatever, we need to look at the rate per person. So here in the United States, as of last night, we had 750,000 cases and 40,000 deaths. Look like astronomical numbers. And they are astronomical numbers. I mean, I don't want to make it sound like they aren't. They really are serious numbers. But when you throw this into comparison, this is the deaths for the last 7 years from CDC of the flu in the United States. And you take these numbers and you total them and divide them by 7, they average 35,000 deaths per year from the standard flu. So you take these 35,000 deaths from the standard flu each year and you compare it with C19 and you've got 40,000 to date. This is not good, but do you see where I'm trying to make the point that we tend to overestimate the importance of a number if we don't have a comparison number to put it in? When you say, when I compared today, so far we've got 40,000 deaths from C19, but in a standard year, an average year, we have 35,000 deaths from the flu. It puts those two numbers in comparison, and they may not look as impressive as they did in the beginning. So here's that chart that I just pulled that from. These are the CDC from each of the 7. There's some partial data on 2018's flu season, but these are the 2007 ones, and this is a number of people who they think caught it. These are a number of people who actually went and had a doctor visit or had one or more doctor visits. And so you got 12 million in the United States, or 36,000 people per million, or 3.6% of the population went and had a medical checkup or a medical visit as a result of the flu on an average year. Of those, you have 1,200 of them actually were serious enough so they had to go to the hospital, 1,200 per million, or a total of 390,000 on an average year. Now let's take this 390. This is an average number of people who went to the hospital with a bad case of flu in these 7 years. And we look at individual years and you see a 500,000, a 590,000, a 570,000 ones. And admittedly, you see some low ones here, 140,000. But look at these bad years. You see 500,000 to 600,000 on a bad normal year. Now let's go back one, and we look at and what we're counting with this number here, number of cases. Because we don't have the test kits, this is primarily counting the number of hospitalized people. People that are sick and are at home are not yet being counted. We don't have any testing kits for them. There's no drive-by test places that I'm aware of that are that have a reliable test. And so these are primarily people who are in the hospital and have been hospitalized from what they think or know is C19. And now you come back over to this one, and this is hospitalizations up here, and this is the average year is 390,000, and you see years where there's 500,000, 570, 590,000. It's not horribly different from this number. Surprising, isn't it? And that's the problem with not comparing numbers. Now, I think, Michael, you mentioned this earlier that, well, let's, what's the data? What's the data by country? And let's compare that. So this is the data by country, and this is the number of deaths that they've occurred divided by their population. So everything has been put down to a deaths per million, which is a good way to, because then small countries are not underrepresented and big countries like China are not overrepresented, because you got everybody down to a deaths per million. So what's happening here? Well, first one is this dashed line was from the previous chart, was the average number of deaths from the flu in the United States is 106 deaths per year, per flu year. So that's what you would expect from an average flu based on the last 7 years. And then you start to look, okay, well, how is that happening in other countries? Well, Belgium, Spain, Italy, what kind of happened to those countries? The thing came on so fast that they exceeded the capacity of the health system and the healthcare workers to handle the cases. So far more people died than would have had they not exceeded the capacity of the system. Here in the United States, we're right about at the average. As of last night, we're right about at the average number of deaths from C-19 that we have on an average flu year. Sweden is allowing people who are, I think it's under 60, to continue to go out and maintain social distances, but they can still go to the bars, to the restaurants, to the malls. And so they're taking an approach, and because they're taking that approach, more people are getting sick faster because they aren't quarantined. And then some percentage of those people that get sick wind up in the hospital. So perhaps more people are winding up in the hospital. And then because of hospitalization, we don't have good drugs for this. More people are in the hospital, more people are going to die. Sweden has a higher death rate than the United States does on a per million basis. But in the US, we basically have a fairly strong quarantine, about as strong as you can have outside of an autocratic country like China. And Sweden has taken a completely different approach and let the I think it's under 60-year-olds continue to go to malls. Maybe it's the under 50-year-olds continue to go to malls and go to bars and mix, just try to maintain social distances. And if you're feeling sick, self-isolate yourself. And the numbers are not as different as you would think. Here is a case of this. Now this one is the number of hospitalizations, which we know. We don't know how many cases because we don't have a good way to measure the number of cases, nor does any other country in the world. There just simply are not enough test kits out there to test people and find out how many people have it and don't have symptoms, or have it and recover themselves. So the only things that we can compare is hospitalizations, because that compares this year versus last year's flu season compares fairly well. Now, in a typical year, based on the last 7 years, 1,200 people per million in the United States wind up in the hospital from the flu. Okay, how does that compare with what's going on this year? Well, this year, as of last night, roughly double the number of people. And we're not through the season, remember. We're comparing this is a completed season. The dashed line is a completed season, completed flu year season. And this is an ongoing flu year season. So ongoing, we've already had twice as many people hospitalized as we would have in an average flu season. And that starts to approach the capacity of the hospital and the healthcare system, certainly probably exceeded it in New York City for a while, but it's not, it's within the range. You get down here to Spain and you see that they really did exceed the capacity of their hospital system. And so you get more deaths coming out of it because they just can't care for the number of patients they have. Now I want to go back to Sweden because I want to talk again about Sweden has this unusual, the only country in the world that has a non-quarantine. Well, they are quarantining the people over, self-quarantine the people over 60, people under 60 basically are free to continue to go to work, to bars, to malls, just self-isolate if you're feeling sick, and try to maintain the social distancing, the 6-foot distance from others. So you see Sweden's using this non-quarantine approach has fewer cases per million than United States has. Now maybe the C-19 arrived in Sweden later than it did in the United States. Maybe that's the explanation. We won't know until the end of the season. But isn't that interesting? Still, I mean, this is major policy decisions are being made on these without good information. Through no fault of the policymakers, but there just isn't good information. We just don't have the answer to these questions yet. Do we have any questions on that?
We have one that says, how do we open up the economy without active, accurate testing? Shouldn't that be our top public policy priority?
Love the question. Great question. I'm giving a talk on that on Wednesday morning on basically, should the United States adopt a modified Swedish approach to its quarantine, because the ramifications from an potential economic collapse due to C-19 could be as serious or more serious than the pandemic. 20% of the people without jobs is a very, very serious situation when most of them don't have the savings that allow them to maintain their lifestyle without a job. And yeah, both the situation on that ship and on the Princess Sapphire are interesting. They indicate a lot of the spread. I've also seen a very well done study last night out of China where one person from Wuhan was visiting relatives in another city that had not yet been exposed, went out to dinner with them, and as a result, they were able to identify that the 9 surrounding people, for a total of 10 people, caught C-19. And that was out of 20 people that were in the air path to have been exposed, that were highly likely to have been exposed. 20 people were sitting close enough and in the air path to blow whatever atomized viruses or speaking droplet viruses were being spread around by this person who had not yet shown any symptoms. But since 100% of those 20, all 20 were exposed and only 10 came down with it, were the other 10 infected but their own immune systems handled it. There's so many unanswered questions to this thing that we just don't know. That indicates a highly contagious virus. When you sit down with 20 people where the air conditioner is blowing the air back and forth between these 20 people, and 10 of them come down with it, 8 of them look like they were, 7 of them look like they were directly infected, and 2 of them may have been infected by the first person in their family getting infected and then reinfecting them. But it's contagious, and one has to be very careful when one talks about changing the quarantine system, and do not yet have tests. there'll be two basic tests. There's a test done by Abbott Lab that is testing for the virus itself. That is, it is testing whether the person has the DNA from the virus through a swab sample in their nose or throat. And it grows, it multiplies that, and then tests to see if the virus is present. So that would say the person has the virus. It doesn't say they have C19 yet, but it says they definitely have the virus inside their body. And there's a completely separate test. That is an antibody test, tests that you in fact had C19, that you got over it, and that they can test that your bloodstream has antibodies in it. It doesn't tell you whether you have C19 now or whether you are carrying C19 or whether but it tests, does your bloodstream have the antibodies that will fight it off and you probably won't get sick from it. These are two tests that we need to have, and neither of them are available in quantity. And this is the reason that the quarantine is difficult to change. But it's also going to be difficult if we can't be in quarantine for the next 6 months. The economy will fall apart.
Regarding your deaths comparison, you're looking at a total country level. You are overlooking the more granular numbers of some hot zones. Example for NYC, 115 per 100,000.
Yes, and that is the real key. The virus appears to be, if the quarantine could be done on a regional basis, New York City should have gone into a deep lockdown, 100% lockdown. Nobody, including the young people, should have been allowed out until the number of new cases and new deaths started to fall and were significantly below, certainly below the capacity of the healthcare system as measured by the doctors and the hospital to be able to treat the projected number of people that were going to come in the next week or two. That should be 100% quarantine. And if that happened in Sweden and say Stockholm, then Stockholm ought to go into 100% quarantine. It doesn't mean, therefore, the rural areas should also be in quarantine, 100% quarantine. And I think that's what we're trying to find out, is it needs to be done almost on a regional basis. From when I used to do this kind of stuff, it's what we call an SMSA, the Standard Metropolitan Statistical Area, which for us would include Tampa, St. Petersburg, Clearwater, and so on, the whole area combined into one area, because that's probably where the virus is going to spread around, and the hospitals are going to become overwhelmed if they do. Orlando would be another one. Miami would be another one. New York City, obviously, one. San Francisco. All of these need to handle this quarantine issue on a regional basis and not pay any attention to the ones that are being lax on it. May be able to get away with it until it starts to spread. The advantage of allowing people to go out is the people who catch the virus and their immune systems are able to handle it easily, build up an immunity and become what are known as an acquired community immunity. And when that number gets big enough, then the virus doesn't have any new people or relatively few new people to infect, and therefore it starts to die out. And this is what the community acquired immunity planned through a planned quarantine system would do. I'm going to run through these next ones here because I really do want to I think the last slide is going to generate a lot of conversation. So generalization, we tend to wrongly assume everything or everyone in a group is similar. We must look for differences within a group and similarities between the groups. And again, we go back to this 80-year-olds. The 80-year-olds are at higher risk, but some of them are healthy. You can be 80 years old and still be healthy and not have a comorbidity and not be at extreme risk. You can be a 20-year-old, be under chemotherapy where your immune system has been shut down and be at high risk. And again, we're looking at the various diseases to try to separate that all out. The cancer patient is probably having chemotherapy and therefore they're at much higher risk. The destiny instinct. We tend to assume that everything is predetermined by certain factors, and that those factors are not going to change, and therefore the destiny going forward is fixed. But we have to be on guard that things and people and groups do change, whether we divide people by country or religious affiliation or racial or whatever, that things that we assign to them, probably incorrectly, can change. People can change, groups can change. And we need to continually update our knowledge in order to be always looking for that change. And an example of this is worldwide people gradually shifted from being unconcerned about C-19 when it first started in Wuhan to becoming alarmed and self-quarantining. So our views changed. If you looked at how we were first behaving, an awful lot of us would have become infected and many more hospitalized and died. But it changed. 8 is a single perspective. We tend to focus on a single cause or a single solution, which makes it easier to grasp the problem and to understand the problem and to solve the problem. But yet, this is a fallacy because most of the time things are not a single perspective or a single cause or a single solution. It's much better to look at problems from a multiple perspectives and to always keep testing your ideas and allow other people to find weaknesses in your ideas. And to always be humble, never to claim you're an expert. I certainly hope I'm not claiming to be an expert in this area. So an example of that single perspective mistake is early on, Trump restricts entry into the US from China. And that was a good call back on January 31st. He was called some bad names for having done that, and the Chinese were unhappy. But it turned out in retrospect to have been a good call. So his solution to C-19 on January 31st is, well, we'll just not allow anybody from China to enter the US. But he should have been also asking what the experts said, and he should have been using February to prepare and to order tests and order ventilators. If we had ordered tests, we might have enough tests to test everybody. If we'd ordered ventilators, we might have been able to have enough ventilators to meet the peak demand. So the single solution in retrospect was a mistake. He should have, this was a pretty good call, but it wasn't, he was treating it as though that was going to solve the problem, when in fact it needed more solutions than just that. It needed tests, it needed ventilators, and it needed time for everybody to prepare and to figure out how we're going to deal with quarantine. So then we go into the blame instinct. And when something goes wrong, we instinctively blame it on somebody like China or Trump. I'm doing that. My C-19 is really a shorthand for Chinese 2019 rather than COVID-19, which is politically incorrect because I'm blaming it on China. But we know it did start in China, and so I'm secretly saying C-19. But we got to resist finding a scapegoat. It wasn't China's China had some what they call wet markets, wild animals, and I'm I think they'll probably get rid of them going forward because they are too dangerous for introducing flu viruses into the world. But we got to resist finding a scapegoat on this. We got to concentrate on the problem. The problem is that these little tiny microbes, these little viruses, are more powerful than we are. We are not the dominant force in the world. They are. And we've got to look for a system and a solution, and not heroes or people to blame. So we got to look right now, we got to look at how can we help out our medical team? How can we help out the hospitals? We can do that through quarantine. We can use Zoom to reduce our isolation while we're in quarantine. And we can start to talk right now about figuring out how to get the economy restarted, because the consequence of the economy being in a full quarantine for 6 months is pretty horrible. But on the other hand, we have this urgency instinct. We have a tendency to rush into a problem, and as if there's no time to try to come up with a solution, or that we may be too late and we addressed this problem too late and we got to rush to a solution. We have that urgency. That's a tough one to fight. Tough one for me to fight is I see a problem and I want to throw in a solution. And that's the urgency thing. And we really need to take some time. So to control that, we take smaller steps and insist on data rather than hunch-based hasty decisions. A good example of that was this malaria drug, repurposed malaria drug, that looked like it was in France with 64 patients. It looked like it had done a remarkable job with the recovery of them. And it turned out, and the drug had been around for 50 years, therefore its side effects were known. It turns out it does have bad side effects. And a number of those 64 people came down with a heart issue afterwards. And therefore you should use it and any other drug with caution. And you shouldn't rush into, oh, we got the solution, let's use this worldwide. And I think that was one of the mistakes that was made by some of the politicians. And I'm a little guilty of that too. And March 15th, Trump says young people are in good health, they're not strongly affected, everybody just needs to relax, we're doing great. Well, maybe this is blaming Trump, but it is a lack of urgency too, and then it becomes too late, and the pendulum swings to the other side. So always be aware of the side effects of hasty decisions, of the hasty decision of not being concerned, the hasty decision of being concerned, the hasty decision that this drug is going to solve it all. And there was another drug that came out on Friday, a really promising one at University of Chicago, made by Gilead, Remins something or other, and it has really good results and is looking very promising. And there's the urgency of rushing to the solution that's going to get everybody better. It did, in fact, the people that were given all of them, I think 2 of them died, and it was only given to very sick people. 2 of them died, and the other 60 recovered within 5 days, which was fast. Okay, and here's the slide I keep pumping here that I wanted to spend some time on. This is a new study that came out this morning, Stanford antibody tests, where the problem right now is there are not enough tests, and therefore you're not supposed to test anybody who has not got known conditions to be pretty certain they have C19 before you even test them. But Stanford must have gotten permission, and they went around and they tested 3,300 people that they picked randomly out of a Facebook ad. And they found that 2.5% to 4.2% had the antibodies, indicating that they had already been infected with, and their bodies, even though they were not aware of it, that their bodies had beat off the C19 virus. Now, the reason that this is so important is that if this is true, and they say this is in their study, and they admit it's a yet to be peer reviewed and so on, they say 50 to 85 more people have caught and successfully fought off the virus than the number of confirmed cases. Now, the reason this is such good news is if there's 50 times as many people have already caught the virus and fought it off, number one, is not as serious a virus. That is, the percentage of people that are being hospitalized and die from it is a much smaller percentage if you have 50 times the number of people to divide that by. And it also explains why the virus doesn't infect and hospitalize everybody. The reason is because a lot of people have already got the virus and therefore are now immune to it to some extent, or immune from catching it a second time. So this would suggest that the true fatality rate is somewhere around 0.12 to 2. Now, 0.12 is roughly the annual virus, I think. And it's not what the World Health Organization is saying, 3.4%. And then they go on the same study, and others on this study, the review of this study, say, well, you know, actually in New York City, they tested all 100% of incoming pregnant women before they gave birth, even though they didn't qualify for the C19 test, and they found that 10 times the reported cases, they had 10 times the number of cases that were reported as the average infection rate. And if they were representative, that means 10 times as many people in New York City actually had it and got over it than were being reported as having got it. And then they looked at other studies, and in Italy, they found a 30 times ratio, in Iceland, 10 times ratio, in Germany, 14 times ratio, and in Denmark, 27 times the number of people actually have it than are being reported to having had it. This is amazing news if it's true. And I went this morning and I read the 47 critiques that other people had sent in on the web from reviewing this study, and they were all over the place. Some were saying, fabulous study, well done. Others were saying it had major defects. Some saying that the antibody tests that they had test for other coronavirus antibodies, and therefore it would pick up an antibody that you got if you had been recently infected with one of these other cold type viruses, which is probably true. And then there are tests that you can take of the people that were positive. There are tests that have not yet been done that can determine whether it was a normal cold virus that it's picking up as a positive, or whether it was in fact C19. So these are all yet to be done. This is all brand new information that is really creating a firestorm among the medical community. But the news this morning is, who knows? This may be, many more of us may have already got this and self-cured ourselves with our own immune system, which means that the virus is going to die out because there's going to be relatively few people who have never seen the virus to get infected, and that's the way a virus dies out. I think I've said that this is promising, but yet to be reviewed information that let's hope. Let's cross our fingers and hope. This is, I mean, why in New York City have the numbers started to level out if there aren't a large number of people who have somehow got the antibodies, which is probably they got the antibodies by having gotten infected with it and they didn't even know they were infected with it.
And thank you very much for all the information this morning and having it so up to date. And anybody else who wants to join in, I know it's almost time to shut down, but I think it all stems from the very beginning. And the very beginning is, unfortunately for us, we are flying blind in this pandemic. We are fogged in at 2,000 feet altitude. We can't see where we're going. We're only visually rated. We do not have instrument flight rules, and we're not instrument rated. We're trying to figure out where to go. Our control tower, the WHO, the World Health Organization, the CDC, are giving us verbal instructions based on what they're seeing on their radar, but they aren't where we are hovering or sheltering in place in this fog. We're waiting to get visual, accurate information. And when the weather clears, we might find out we are totally off course, or I hate to have the analogy of Kobe Bryant, but if there's a crash, of course, economically speaking, we could find ourselves crashed and still don't get to where we need to be. So, unless we get accurate information on the front end, which we still don't have, everything after that is based on guesstimates and judgment. And that is not a good place to be. So I happen to think, even with the homogeneous, isolated population of Sweden, that it's worth, at this point, a try to let those who have a bunch of comorbidities, over 60 or older, get out there, let the herd immunity try to kick in, and see what we get without totally taking for another year our economy. So that's my opinion and discussion, and I'm sure there's people who disagree with me.
Well, Michael, no disagreement from me. That is exactly my conclusion, and you couldn't have summarized my talk better. Thank you. Yeah, just remember, I'm as I keep saying, I'm not a medical doctor who probably have a better, no question, they have a much better handle, or a researcher. It was fun. I hope everybody had fun and realized that we're just, as Michael said, we do not know. We're flying blind here, and treat this as a fun experience. We're trying our best to figure out what's the best thing to do, and not crash the economy in the process.
Well, thank you, and have a great day, everyone.
Thanks again.